Good morning, everyone. Welcome to High Rounds. Today we have the pleasure of having one of our colleagues from Owen Clinic, Dr. Amutha Rajagopal. She's going to be speaking to us about a brief overview of hepatitis D virus infection. Just a little bit about Dr. Rajagopal. She completed her medical degree at UCSD. And then residency at internal medicine at Scripps Green Hospital in La Jolla. She also completed a residency in general preventative medicine at UCSD. She completed her ID in global health fellowship at University of Chicago. And currently she works here at UCSD Owen Clinic, caring for patients with hepatitis C, opioid use disorders, and HIV. So we're glad to have Amu here to talk about acute hepatitis D. So go ahead and take it away. I see you're playing with the slides a little bit.
Okay.
All right. There we go.
Okay, good to start.
Yep.
Okay. This morning I'll be providing a brief overview of hepatitis D infection and where we are with regards to treatments. I was personally inspired to pursue this topic by a memorable patient who I diagnosed with hepatitis D unexpectedly in PrEP clinic in the past year. And I needed to update my own knowledge about where we are with this infection, especially because I'd never had a patient with chronic hepatitis D infection before. And generally, it is an infection that is rarely seen and discussed. There was also an excellent presentation on hepatitis D infection, fortunately for me, at CROI earlier this year by Dr. Begelen. I have no financial disclosures or conflicts of interest to report. Okay. So the patient I met in clinic had no medical conditions that he knew of and was presenting for starting PrEP. His risk factors for HIV included unprotected sex with multiple sexual partners, while he reported no history of STDs. His lab tests notably revealed the presence of hepatitis B surface antigen, a reactive core antibody, and reactive E antibody. He had negative hepatitis B antigen and surface antibody. He had a low level elevation of hepatocellular enzymes, and his hepatitis B viral load was low but detectable. So transient elastography in clinic showed evidence of advanced fibrosis. An ultrasound of the abdomen showed numerous hyperechoic lesions throughout his liver. An MR elastography showed evidence of advanced fibrosis and a cirrhotic appearing liver without evidence of portal hypertension. No evidence of iron overload or steatosis, and that hemangiomas were likely the lesions of the liver seen on the ultrasound. So I asked the patient if he had ever been diagnosed with hepatitis B infection before, and he said that he was told he had cleared the infection around 25 years ago, actually, and had underwent a liver biopsy at that time, which we didn't have results from. He said he was told that he did not need treatment and was cured actually without getting treatment at that time. He reported no known medical diagnoses otherwise, reported taking no medications or supplements. He had moved to the US from Torino, Italy 30 years ago, reported no history of drinking excessively or other regular use of recreational drugs. He exercised regularly. He had a normal BMI, no evidence of diabetes or hyperlipidemia in his labs. So no explanations yet for his degree of liver fibrosis on elastography, at least, except a chronic hepatitis B infection. His hepatitis D antibody test, however, did also return positive, and I ordered a send out test for hepatitis D viral load, which returned greater than 300,000. Liver biopsy was then planned as the standard for staging of fibrosis with hepatitis D infection. Okay, so now I'll go on to a discussion about hepatitis D infection. And my objectives are to provide a brief introduction to viral pathogenesis, epidemiology, natural history, screening, diagnosis, and where we are today with treating hepatitis D infection. So in the late 1950s in Brazil, in the Western Amazon basin, clusters of a peculiar severe hepatitis were labeled Librea black fever or Librea hepatitis. And these cases of hepatitis appeared to share features with cases later described from other countries in South America and in the Central African Republic. Later in the 1980s, hepatitis B DNA and hepatitis D RNA were identified in the liver samples of people who died of Librea hepatitis, supporting hepatitis D infection as a risk factor for the development of fulminant hepatitis. So the hepatitis D virus, or otherwise also called as Delta virus, was discovered in 1977 as a virus with a unique antigen presenting only in persons carrying the hepatitis B surface antigen. And while it is the least common chronic viral hepatitis in humans, it is also been found to be the most severe. Since the 1980s, the worldwide presence of hepatitis D virus has become more apparent. The genome of the hepatitis D virus consists of a circular single-stranded RNA molecule, and there appears to be high heterogeneity in the makeup of its genome worldwide. 8 hepatitis D genotypes have been described. The RNA molecule is folded into a rod-shaped structure with a single and unique structural protein called the hepatitis D antigen or delta antigen. The infective form of the hepatitis D virus consists of the RNA antigen complex surrounded by a lipoprotein envelope that importantly consists of the hepatitis B surface antigen. And the hepatitis B surface antigen in the envelope of hepatitis D virus is the crucial and essential helper function provided by hepatitis B that enables hepatitis D to exit hepatocytes and infect hepatocytes. Cellular entry of both hepatitis B and D viruses is mediated by the sodium terocholate cotransporting polypeptide, or NTCP, which is a transmembrane protein expressed largely in the membranes of hepatocytes and normally serves in the uptake of bile acids from plasma. After the hepatitis D virion loses its envelope and the ribonucleoprotein gets imported into the nucleus, hepatitis D gets transcribed into antigenomic RNA and mRNA using host RNA polymerases. These RNA polymerases ordinarily use DNA templates for RNA synthesis in our hepatocytes. Hepatitis D mRNA then gets exported to the cytoplasm of the hepatocyte, where it is translated at the endoplasmic reticulum to form hepatitis D antigen. Hepatitis D antigen returns to the nucleus, where it helps regulate more replication of hepatitis D from RNA polymerase. And the delta antigen also binds new genomic RNA to form ribonucleoproteins. And so far, the formation of the hepatitis D RNA antigen complex has not really required hepatitis B at all. However, the virus cannot exit the hepatocyte or infect other hepatocytes without a lipid envelope that consists of hepatitis B surface antigens. So viral pathogenesis varies and depends on the mode of both hepatitis B and hepatitis D infections. A simultaneous infection of hepatitis B and hepatitis D, called coinfection, will lead to acute hepatitis that resolves spontaneously in the majority of people. Whereas hepatitis D superinfection of a chronic hepatitis B carrier will mainly result in chronic hepatitis D infections. Our knowledge about the prevalence of hepatitis D, however, is severely limited by lack of testing, probably due to the lack of awareness about hepatitis D infection combined with lack of accessible diagnostic tests. In the US, hepatitis D is not a nationally notifiable condition, actually. So the actual number of hepatitis D cases in the US is unknown. It is estimated about 4% of the global population, around 350 million people, have chronic hepatitis B infection. And among those with chronic hepatitis B, 5 to 10% are also infected with hepatitis D, or an estimated 15 to 35 million people globally. Viral hepatitis in general is estimated to cause a little more than 1.3 million deaths annually, and 66% are attributed to hepatitis B infection. But what fraction of hepatitis B associated mortality involves hepatitis D remains uncertain. While it's known that hepatitis D is generally associated with the most severe forms of acute and chronic viral hepatitis. Fortunately, there appears to have been a significant decline in the incidence of hepatitis D infection globally, driven by increased vaccination against hepatitis B. So hepatitis D infection and its genotypes are not distributed uniformly across the globe. And although hepatitis D is an obligate satellite virus of hepatitis B, the distributions of the two viruses do not actually parallel each other. Many Asian countries that have a high prevalence of hepatitis B, for example, are relatively spared from hepatitis D infection. The reason for the differences in distribution may be due to differences in the most common routes of transmission of these two viruses, which I'll mention. Hepatitis D is endemic in the Amazon basin, the Mediterranean, Middle East, West Africa, and some other parts of Africa, and certain countries in Asia, with especially high rates in certain countries such as Mongolia and Pakistan, where it's been estimated that 60% of people with chronic hepatitis B are seropositive for hepatitis D. It's also endemic in some areas in the Pacific. Both hepatitis D and hepatitis B are transmitted via parenteral routes. However, hepatitis B is much more commonly transmitted by vertical and sexual transmission compared to hepatitis D. The highest risk population for hepatitis D infection by far that's been identified is persons who inject drugs. Recipients of hemodialysis, men who have sex with men, and commercial sex workers also appear to be at higher risk of hepatitis D infection. Among people living with HIV globally, there appears to be a particularly high prevalence of hepatitis D among those who inject drugs. However, among people with HIV who do not inject drugs, the prevalence has been estimated to be similar to that of the general population. In the US, hepatitis D infection appears to be rare and confined to people who inject drugs and persons who immigrated from countries where hepatitis D is endemic and where there are also poor hepatitis B vaccination rates. So in terms of the clinical presentation, the signs and symptoms of acute hepatitis D infection are indistinguishable from other acute viral hepatitis. Symptoms typically occur 3 to 6 weeks after an infection, and the clinical spectrum can range from mild to fulminant hepatitis. For most people with hepatitis B and D co-infection, a disease usually has a self-limited course, and less than 5% of people who are co-infected will go on to have chronic hepatitis D infection. This is similar to how most adults who acquire hepatitis B infection alone do not develop chronic hepatitis B. Those who are co-infected, however, are more likely to have liver failure than people with hepatitis B monoinfection. And co-infection results in fulminant liver failure in about 1%. In general, hepatitis D superinfection leads to a more severe course. Superinfection results in fulminant liver failure in 5% of people. And chronic infection occurs in the vast majority of people who are superinfected. The chronic presence of hepatitis B surface antigen enables the continuous replication and infection of hepatocytes with hepatitis D after superinfection occurs. Chronic hepatitis D infection has been shown to accelerate liver fibrosis, hepatocellular carcinoma, and liver decompensation. With hepatitis D superinfection, cirrhosis has been estimated to occur within 5 to 10 years in 70 to 80% of people, and liver failure in 1 to 2 years in 15% of people. By comparison, the mean age of onset of cirrhosis in persons with chronic hepatitis B monoinfection from childhood is 3 decades. Okay, hepatitis D replication specifically is associated with having poor outcomes. About 60% of individuals who are seropositive with hepatitis D are found to have viral replication. And viral replication in particular has been associated with poor overall survival, as indicated by the solid black lines in the graphs in the red box. increased liver-related death and hepatocellular carcinoma compared to RNA-negative individuals represented by the dashed lines. So multiple viral and host-specific factors appear to be associated with disease severity with hepatitis D infection. Some experience rapid development of cirrhosis, while few others may have a stable chronic infection with hepatitis D and be asymptomatic carriers. Associated viral factors include the levels of hepatitis D replication, hepatitis D genotype, hepatitis B genotype, levels of hepatitis B replication, and then the presence of other viral co-infections such as HIV or hepatitis C. And then host factors that have been associated with more severe disease include older age, male sex, and host-specific immune functioning. Differentiating between co-infection and superinfection relies mainly on the detection of high titers of IgM to hepatitis B core antigen. Serum hepatitis D antigen appears early in hepatitis D infection, while short-lived usually, and also it's therefore rarely useful for diagnosis. In chronic infection, hepatitis D antibodies are present in high titers, and viral replication can be detected by reverse transcriptase PCR. While commercially available, no assays for hepatitis D RNA quantification have been approved for clinical use by the US FDA, and there's a high degree of heterogeneity in the sensitivity and specificity across hepatitis D RNA assays. Antibodies typically can be detected by about 4 weeks of infection. And IgM hepatitis D antibodies are present in high titers during acute infection, and both IgM and IgG are often high during chronic infection. And the titers appear to correlate with the level of replication and severity of liver disease. Chronic infection is characterized by persistent detection of hepatitis D RNA after 6 months. Of note, serum hepatitis B DNA is not infrequently actually low or undetectable in the presence of chronic hepatitis D infection. And it's been found that hepatitis D superinfection can suppress hepatitis B replication due to unclear mechanisms, resulting in a very low and sometimes even undetectable level of hepatitis B virus, as was seen with my patient. So at present, there are discordant guidelines internationally regarding who should be screened for hepatitis D infection and how to perform it. The European Association for the Study of the Liver recommends screening in all people who have a hepatitis B surface antigen. The Asian Pacific Association for the Study of the Liver recommends screening all people with chronic hepatitis B infection. And in 2018, the American Association for the Study of Liver Diseases, by contrast, recommended risk-based screening for hepatitis D. So AASLD recommends screening people who have hepatitis B surface antigen and are from endemic parts of the world, have ever injected drugs, men who have sex with men, individuals infected with hepatitis C or HIV, persons with multiple sexual partners, or any history of sexually transmitted infections. Also, those who have elevated ALT or AST with low or undetectable hepatitis B DNA. And so this might be a lot of groups to remember maybe. But these guidelines also state that if there exists any uncertainty at all regarding a person's risk, hepatitis D screening should be recommended for a person with surface antigen, hepatitis B surface antigen. The testing cascade recommended is antibody testing followed by RNA testing to diagnose active infection and not the delta antigen of note. In a study of patients with reflexive hepatitis D screening in all persons with hepatitis B surface antigen, 60% of people diagnosed with active hepatitis D replication did not have an identifiable risk factor for hepatitis D infection, which suggests that screening by risk factors alone may be suboptimal. So in general, less than 10% of those with hepatitis B surface antigen in the US are screened. It's been shown, however, that when reflex hepatitis D testing has been implemented for positive hepatitis B surface antigen results, 5 times as many hepatitis D infection cases have been diagnosed. A rapid point of care test for serodiagnosis of hepatitis D has been recently developed, while not commercially available yet. So on the left, hepatitis B monoinfection is indicated by the blue figure and co-infection in orange, showing that the risk of hepatocellular carcinoma is 3 to 6 times greater with co-infection compared to hepatitis B monoinfection. And international guidelines vary in terms of recommended populations for screening of hepatocellular carcinoma as well. But based on the significantly increased risk of co-infection, multiple organizations, including AASLD, recommend screening all persons who have hepatitis D infection, irrespective of the stage of fibrosis, at least every 6 months with ultrasound with or without alpha-fetoprotein. In terms of staging fibrosis in persons with hepatitis D infection, liver biopsy is the gold standard for assessment of fibrosis, as there are no studies reporting correlations between liver biopsy and elastography with hepatitis D infection, which would be helpful information to have in the future. And then scores utilizing serum biomarkers are also not well correlated with fibrosis estimates, and hepatitis D infection is often artificially elevated in the presence of the severe hepatic inflammation. So now I'll move on to discussing where we are with treatment of hepatitis D infection, and begin by stating that to date, no pharmacologic therapy is able to cure hepatitis D infection, and the optimal treatment is frankly unknown. So one major formidable barrier to eradicating hepatitis D is our inability to achieve a cure for hepatitis B infection first, which plays a central role in hepatitis D infection. We also do not have a good functional cure for hepatitis B infection that at least results in the loss of hepatitis B surface antigen, albeit the presence of cccDNA and integrated hepatitis B DNA. Patients who have cleared hepatitis D, but still have hepatitis B surface antigen are still at risk of hepatitis D reinfection. The development of hepatitis B surface antibody has been shown to offer protection from hepatitis D virus. Another challenge is that unlike hepatitis B and C viruses, which both produce specific enzymes for the process of viral replication that can be targeted with treatment, hepatitis D virus uses a host RNA polymerase for its replication. So this slide shows the efficacy of currently first-line therapies for chronic hepatitis B infection, and the standard of care therapies for hepatitis B, which include nucleoside and nucleotide analog inhibitors and PEG interferon, are effective in reducing hepatitis B viremia and aminotransferase elevations. Treatment with nucleoside and nucleotide analog inhibitors results in hepatitis B DNA suppression in greater than 90% of people with chronic hepatitis B E antigen negative infection and 73% of E antigen positive chronic hepatitis B, which has been associated with a decrease in important long-term complications, actually. However, as highlighted in the red boxes, all available treatments for hepatitis B infection rarely lead to the loss of hepatitis B surface antigen, which is the crucial ingredient needed by the satellite virus. Skip that slide. So pegylated interferon compared to the nucleoside and nucleotide analog inhibitors results in higher rates of hepatitis B surface antigen loss. Notably, about 8 to 10% of people receiving PEG interferon alpha for 1 year clear hepatitis B surface antigen in follow-up 3 years later. However, even after 10 years of treatment with the nucleoside and nucleotide analog reverse transcriptase inhibitors, only 2 to 3% or less have a loss of hepatitis B surface antigen. So I'll quickly review reasons for the persistence of hepatitis B surface antigen and the barriers to eradicating hepatitis B that challenge a cure for hepatitis D infection as well. So following entry into a hepatocyte via NTCP, the hepatitis B virus loses its envelope and gets transported to the nucleus. The hepatitis B life cycle is unique in that its DNA, which is relaxed circular partially double-stranded DNA or rcDNA, gets converted in the nucleus to a stable mini chromosome called covalently closed circular DNA or cccDNA. And cccDNA usually persists throughout the lifespan of a hepatocyte and provides a sort of permanent template for hepatitis B RNAs, including pregenomic RNA, which can be used for further replication. and mRNA for viral protein synthesis, including for the hepatitis B surface antigen. So while treatments with nucleoside and nucleotide analog inhibitors inhibit hepatitis B DNA synthesis by inhibiting viral reverse transcriptase, which replicates or generates the DNA from pregenomic RNA, they have no impact on CCC DNA once it's established in the hepatocyte, and no effect on the synthesis of pregenomic RNA from CCC DNA, which is by host RNA polymerase. Nucleoside and nucleotide analog inhibitors also do not impact hepatitis B surface antigen expression from pregenomic RNA from CCC DNA. Another important source of hepatitis B surface antigen expression outside of CCC DNA is hepatitis B DNA that's integrated into the host genome, which is highlighted in 4B of this diagram. So this is still a source of surface antigen, even if CCC DNA is silenced. The structural arrangement of the integrated hepatitis B DNA affects the expression of all viral open reading frames, except for that of hepatitis B surface antigen. So this may not be a source for replication of the virus, but it is for surface antigen. Interferon has both antiviral and immunomodulatory effects, though its precise mechanisms remain unclear. But there is some evidence that interferon can enhance the degradation of CCC DNA and exert epigenetic modifications of CCC DNA, which potentially explain its greater impact on hepatitis B surface antigen production compared to the reverse transcriptase inhibitors. Higher levels of hepatitis B surface antigen are also associated with impairment of host T and B cell immune functioning, which is a barrier to clearance of hepatitis B infection in general. So in summary, as mentioned, the chronic production of hepatitis B surface antigen from hepatocytes from CCC DNA and integrated hepatitis B DNA both allow for the continued assembly of hepatitis D virions, even when we can suppress hepatitis B replication. And we do not have treatments right now that can eradicate covalently closed circular DNA and integrated DNA. So if eradication of hepatitis B or D are not achievable with the currently available and approved treatments, what may be reasonable preliminary goals for therapy for hepatitis D? So the FDA drafted some guidelines in 2019 for the development of treatments for hepatitis D infection. And this included goals of preventing the complications of hepatitis D infection, progression to cirrhosis, liver decompensation, hepatocellular carcinoma, and liver-related death. Practical challenges to proving such outcomes, of course, for drug development would include a need for large study populations and long-term follow-up. Thus, surrogate markers for clinical improvement consists of normalization of ALT and virologic suppression that have been used to measure efficacy of treatment. In terms of laboratory efficacy endpoints that have been suggested for drug development, goals include undetectable hepatitis D RNA and hepatitis B surface antigen loss. Off of treatment, ideally, in a high percentage of patients, or at least with tolerable treatment. Most studies, however, have focused on a more preliminary goal of just reducing hepatitis D RNA levels and aminotransferase levels. This is due in part to one study which showed an association between viral decline and survival benefit, and specifically that a greater than 2 log reduction in serum hepatitis D RNA from baseline is associated with better outcomes. And so this was proposed by an expert panel as a preliminary treatment efficacy goal in clinical trials. So although not FDA approved for the treatment of chronic hepatitis D and also having poor outcomes, interferon alpha currently remains the standard of care treatment for hepatitis D infection. Published experience for its use with chronic hepatitis D is less than for other viral hepatitis infections. Notably, interferon alpha in vitro studies has not been shown to have specific antiviral activity against hepatitis D virus, so its efficacy may depend on its effects on hepatitis B or immunomodulatory effects. The largest multi-center trial of interferon alpha for hepatitis D infection did not reveal an appreciable benefit. So this was a study done in Italy with 61 patients with chronic hepatitis D who were randomly assigned to interferon alpha or placebo for 1 year and then followed. 25% had a normal serum ALT versus 0 in placebo at the end of 12 months of treatment. And however, all but one had biochemical relapse after discontinuation of interferon. Frequency of undetectable hepatitis D RNA at 1 year after completion of treatment was also not significantly different in the treatment arm. And the treatment arm also did not have significant improvement in liver histology in follow-up after end of therapy. There have generally been mixed results from other studies looking at interferon alpha for hepatitis D infection, but in general, while there is evidence to support a significant virologic response and ALT normalization during treatment, there have been very low rates of sustained effects after stopping. So certain patients may, however, benefit from prolonged interferon alpha therapy, potentially if eradication of hepatitis B surface antigen is used as an endpoint. And there's a few small case series that have supported this. So in one small case series of 4 patients with hepatitis D infection who received interferon alpha treatment, treatment was continued until hepatitis B surface antigen was no longer detected, and patients required anywhere from 7 months to 4 years of interferon to achieve the loss of hepatitis B surface antigen. However, hepatitis B surface antigen remained negative in all patients 1 year after end of therapy. Another case series of 3 of 13 patients that were treated with PEG interferon for up to 5 years, hepatitis B surface antigen also remained or was lost. So these data raise the questions of whether there may be candidates for prolonged treatment with interferon to force elimination of hepatitis B surface antigen, and whether perhaps quantification of hepatitis B surface antigen might actually help in identifying potential future responders to interferon therapy. However, prolonging interferon therapy in general raises huge concerns of tolerance and adherence. Interferon is administered by injection and frequently associated with intolerable flu-like symptoms, cytopenias, and psychiatric complications. It's also contraindicated in people with decompensated cirrhosis or severe exacerbations of chronic hepatitis, and has to be used with caution in with compensated cirrhosis. Multiple studies have evaluated the use of interferon at different doses, pegylated interferon at varying doses and durations, with or without a variety of nucleoside or nucleotide analog inhibitors for treatment of hepatitis D infection, which have had inconsistent outcomes and overall very poor rates of long-term suppression of hepatitis D viremia. Currently, nucleotide analog inhibitors are not recommended for hepatitis D treatment unless indicated for hepatitis B treatment or with having a high hepatitis B viral load. So I'll end the talk by reviewing some of the newer therapies that have been looked at for hepatitis D treatment, which include 3 main drug classes. Bulevirtide blocks hepatitis B and D binding to sodium terocholate cotransporting polypeptide, that NTCP transmembrane protein, and therefore this drug blocks entry of these viruses into the hepatocytes. Lonafarnib is a farnesyltransferase or prenylation inhibitor, and farnesylation or prenylation involves the addition of a hydrophobic farnesyl group to proteins, which renders them more lipophilic and facilitates protein attachment to lipid membranes. So farnesylation of hepatitis D antigen specifically allows it to anchor to hepatitis B surface antigen in its envelope. And lonafarnib essentially has the effect of preventing hepatitis D virion assembly. Unlike bulevirtide, it does not reduce the infection of the hepatocytes by hepatitis D or B viruses and results in the accumulation of viral intermediates inside hepatocytes. REP2139 is a nucleic acid polymer drug that has unclear mechanisms, but essentially inhibits the export of hepatitis B surface antigen-coated particles from the hepatocyte, including hepatitis D virions. And so this also leads to the potential accumulation of subviral particles in hepatocytes. Bulevirtide is administered subcutaneously on a daily basis and has been studied in combination with pegylated interferon alpha and tenofovir, as well as monotherapy. Most patients had transient reductions in viremia with bulevirtide treatment, but the vast majority experienced virologic relapse after stopping it. And 0% notably had a loss of hepatitis B surface antigen. Bulevirtide inhibits bile acid transport into hepatocytes, which is the function of NTCP, and has been associated with asymptomatic hyperbilirubinemia as a common side effect, while treatment has been generally well tolerated and wasn't really stopped for this reason in patients in the studies. So in one phase 2 study, patients with chronic hepatitis D infection were equally randomized to receive bulevirtide, PEG interferon alpha, or combination of both, and virologic response was evaluated at 24 weeks. A reduction in hepatitis D RNA was significantly more common in patients who received combination treatment compared to bulevirtide monotherapy. In the bulevirtide monotherapy arm, 2 of the 7 patients became undetectable compared with 5 of 7 patients who received combination therapy. And levels of hepatitis B surface antigen were unchanged with bulevirtide compared to the other arms. In another clinical trial, the efficacy of bulevirtide was assessed in combination with tenofovir for reducing hepatitis D RNA in 120 patients who had failed interferon or were unable to take it. And so these patients were already on TDF and were randomized to receive bulevirtide at different doses or just continue TDF. Dose-dependent hepatitis D RNA declines were seen with treatment with bulevirtide. However, in follow-up within a year of stopping treatment, a virologic relapse of hepatitis D occurred in the vast majority of patients. This is something I just added today that I found, but basically, so the European Medication Agency approved conditionally the use of bulevirtide, but it's not approved in the US yet, of course. So there's some real world experience from patients in Germany. And this study was just recently published, which showed that 114 patients that were treated with bulevirtide the vast majority of them had virologic response, with 25 patients achieving hepatitis D RNA negativity, and that ALT levels improved regardless of virologic improvement. And that this study actually included a significant number of people with cirrhosis, over 50% of them, and a small subgroup that also had decompensated liver disease. However, nothing has been, well, they didn't report what happened after stopping bulevirtide, and all of these patients have been continued on it. Okay. Lonafarnib, which inhibits virion assembly again, is taken orally twice daily. In a small pilot trial of lonafarnib monotherapy showed that while it decreased serum hepatitis D RNA levels, all patients experienced GI side effects. So subsequent studies have assessed different doses of lonafarnib and in combination with ritonavir as a cytochrome P450/3A4 inhibitor to allow for lower doses of lonafarnib while preserving its antiviral activity. In the LIFT HDV study, lonafarnib and ritonavir were combined with pegylated interferon lambda, which has less side effects than interferon alpha, for 24 weeks. And serum DNA was undetectable at end of therapy in 11 of 26 patients. However, only 5 of 22 remained undetectable and had improved histology 6 months after the end of therapy. None of the patients lost hepatitis B surface antigen. And side effects, especially gastrointestinal, were prominent and led to treatment discontinuation in 4 patients. One of the significant concerns about lonafarnib is the potential adverse effects of intracellular accumulation of hepatitis D particles, and whether this may induce a cytotoxic effect or immune-mediated destruction of hepatocytes. Another concern is that since farnesyl transferases are important host cellular enzymes common to various other cellular pathways, there could be complications from that. REP2139, again, is a nucleic acid polymer that inhibits hepatitis B and D virion secretion. And it's only been studied in an uncontrolled phase 2 study, which included 12 patients with chronic hepatitis D infection. It can be given subcutaneously or intravenously on a weekly basis. Patients received REP2139 monotherapy for 15 weeks, followed by combination therapy with pegylated interferon for 15 weeks, followed by monotherapy with interferon for a total of 60 weeks of treatment. And adverse effects were frequent and included severe elevations in ALT and hair loss. 3.5 years after completion of treatment, 7 of 11 patients had undetectable hepatitis D RNA with Rep 2139, and 4 of 11 had hepatitis B surface antigen loss. So these outcomes are obviously very, very impressive, however, also very clearly limited by the sample size of the study and the lack of a control. And the study has yet to be replicated since this was published in 2017. So as mentioned, a transient but marked increase in ALT levels was observed after introducing with the lonafarnib treatment. However, it was notably after introducing PEG interferon alpha that most of these patients had the ALT elevations. And the authors noted that all remained asymptomatic and that the elevation resolved without actually stopping treatment. The serious side effects were common, but mostly associated with PEG interferon alpha. Oh, lambda, excuse me. Or no, it was alpha actually. Importantly, none of the patients that were included in the Rep 2139 trial had cirrhosis. And so aminotransferase flares are going to need further investigation if the treatment is extended to those with advanced fibrosis. Also, the molecular mechanisms underlying Rep 2139 are unclear, and it is unclear, again, if the accumulation of subviral particles in hepatocytes may result in liver damage and increased risk of hepatocellular carcinoma. In terms of prevention of hepatitis D infection, fortunately, we've had a very effective vaccine to prevent hepatitis B infection for about 4 decades, and vaccination against hepatitis B is a proven means to prevent hepatitis D infection as well. There's also some animal studies to suggest that vaccine strategies for hepatitis D may be also feasible for those already infected with hepatitis B. Chimpanzees who were re-challenged with hepatitis D virus years after recovery from initial hepatitis D infection appeared to be partially protected from reinfection, suggestive of a protective immune response. And then to summarize, so hepatitis D is underdiagnosed, and due to the absence of identifiable risk factors in many individuals, we should probably screen all people with hepatitis B surface antigen. Hepatitis D accelerates liver complications, including hepatocellular carcinoma, which should be screened for. And especially while treatment is insufficient, future elimination will also likely depend on better vaccination for hepatitis B prevention. And that was my last slide.
All right, thank you, Amu, for a great overview over what's going on these days with hepatitis D. So I think we'll go ahead and open up the, I guess, the session to see if there are any questions. It was quiet in the chat pod today, but I'll stop here and see if there are anyone wants to unmute and ask a question or type in the chat pod.
I have a question. It's Gigi.
Sure.
Hey, Amu, thanks so much. That was an awesome presentation. My question is about patients who might be PCR positive. And I don't know if there's any literature that speaks to patients who are hepatitis B surface antigen negative, but might have low level Hep B PCR positivity. Is there anything about that in connection with hepatitis D?
Can you clarify that? So the patients that are surface antigen
negative. So core antibody positive, surface antibody negative, surface antigen negative, but might have every now and then a positive Hep B PCR, and they're on Descovy or Truvada.
So as long as someone has hepatitis B infection, they're going to be at risk of hepatitis D infection, because
even if it's pretty well controlled.
Yeah, because like I was mentioning about the CCC DNA and the integrated DNA of hepatitis B, there's always a potential for hepatitis B surface antigen expression.
Okay.
So, and that's the main ingredient that's necessary for hepatitis B.
Okay, Very good. Thank you.
All right, Amu, we have a question or a comment or question from LC. Do you want to unmute?
Hi, Dan Lee. This is Lalo Kachat. Hey, thank you, Amu. Wonderful overview. I have a couple of comments. I think, as you outlined, it's quite important to make a prompt determination of cirrhosis because these patients progress faster, particularly if they have HIV. So my comment is about the staging and the way how even the experts in Europe use FibroScan. I'll use practically the definition that FibroScan in a patient with hepatitis D needs to be taken like someone with acute hepatitis C, where you are really aiming to do it not because you know that it will be overinflated, so it will be reassuring if you do a FibroScan, which is a point of care, bedside, and you have a relatively mid to low fibrosis. So most definitely this patient hopefully will not have cirrhosis because not everybody has an access to a liver biopsy, and many experts in Europe use it practically in that way. That's just a couple of things, and it's important because not only HCC screening, but those patients with cirrhosis immediately are referred for esophageal varices screening, endoscopy, and so forth. And my final comment is, you elegantly explain one and again after again the importance of surface antigen persistence and the only viable strategy trying to see if we can mitigate the damage of hepatitis D. And I want to make a pledge to everybody and remind that we have actually a hepatitis B cure, functional cure, ongoing clinical trial, and think of all of your patients with persistent surface antigen positives to be referred to us through the Antiviral Research Center. Thank you, Ami, for a wonderful presentation.
Well, thank you. And I was hoping that this gentleman's elastography was going to show less fibrosis too, because of what you said.
I guess I'll ask a quick question. So practically, at this point, I think at UCSD, we do not reflexively check for hepatitis D, do we?
No, that's actually one of the motivations for this presentation for me personally was I figured that out with this patient. That not only do we not do reflexive testing for hepatitis D, we also, most people would struggle to find the reflexive testing for a positive result with hepatitis D antibody because it's a send out test and you really have to actually have to order it as a lab miscellaneous test. And the other thing that makes it more like problematic is that what is available in our system right now is hepatitis D antigen, which is not useful usually and is transient and it's not recommended for diagnosis of active infection. So, but that's the one that's actually available in EPIC easily. And so what I've seen happen because I help out with the FibroScans in our clinic is that some people have had hepatitis D antibody testing done and then had antigen testing done rather than having RNA testing done, which is what is supposed to be done.
Are you working on that?
Yeah, I actually emailed Dr. Ritter and forget the person who leads with her, Dr. Pride. I emailed them about this issue, and the last thing I heard was about working on it. So hopefully.
Okay. Any other thoughts or comments?
Hey, Amo, it's Lucas. Great talk. I just, sorry if I missed it, if you said it and it was along the lines of what Lalo was saying. Is there any relationship between hepatitis D and HCC and increased risk of HCC for those co-infected with Hep D?
Very much, yeah. 3 to 6 times is one of the estimates that I saw in the study. But yeah, it's recommended by AASLD and some other organizations, international organizations, that everyone with hepatitis D infection, regardless of stage of fibrosis, should be screened for hepatocellular carcinoma every 6 months, at least.
Thank you.
Yeah.
Any other thoughts or comments? Nope. All right. Well, Moo, please make sure you check the chat pod. Lots of kudos to you, and thank you again for an excellent presentation, and thanks everyone for attending. we will go ahead and end today's session then, and plan to see you next week. So everyone have a great week and take care.